Good evening, everyone, and welcome to this Support for Doctors Returning to Work in the Pandemic Knowledge Refresher webinar. This one tonight is on resuscitation and advanced life support. My name is Dr. Lizy Townshend, and I'm very pleased to introduce Professor Sheona MacLeod, Health Education England's Acting Director of Education and Quality, and our Executive Medical Director as well. Thank you so much for joining us, Sheona.
Thank you, Lizy. I'd like to take the opportunity to thank everyone, first of all, for engaging. The fact that you've signed on, the fact that you're doing some learning, you're responding to an unprecedented time of pressure. And I know some of you have been asked to engage in a way that was somewhat clumsy. But the reason for that is that the planning for how the NHS can respond to this and the horrors of what it might actually be like has made the whole of the NHS consider how can we manage this so that we give the best care to patients with COVID and to other patients. And it was clear from very early on that we were going to need additional support in the form of more doctors. And the fact that you've stepped up and are considering how to do it is a real credit to all of you as individuals. I think one of the things that's important is to be aware that this isn't going to be the very short episode that we saw some of originally, where there was a huge surge. The measures that have been put in place appear to be being effective, and we're now looking at something that's going to be much more of a marathon. So I think especially if you're thinking of coming back to practice, don't feel pressurized to do it instantly. You want to feel confident and you want to have thought about what you're doing. I would really encourage you to come back if you can, especially those of you who are thinking you might come back into training. But the whole of the system has continued to say that this should be about people volunteering and that you shouldn't feel pressurized into doing it. I think for everyone who's working in an environment where they might be exposed to COVID, or even where they're just returning to work or moving into an area of work they don't normally work in, you feel anxious about what it means. You feel anxious about whether you've got the skills, what the disease itself might mean. And one of the things I think it's probably important for you to remember as a group is that that's what a large number of other clinicians are feeling as well. Consultants are moving across to help-in units where they don't normally work and having to ask registrars how to do things. Registrars who thought they were following one career path and are now suddenly realizing that their generalist skills are needed. And then juniors who are being moved around within trusts. There is that, do I feel competent or confident? And one of the things that has really encouraged me has been the focus in the NHS on making sure people have proper induction and are properly supervised. And I think especially if you're considering returning to work, it's important to know that we really do want to make sure that you are appropriately supervised and that you're supported to come back into a working environment. There are advantages in that it might push you into returning, and I can selfishly say that's an advantage for me because I would like to have more doctors back working in the NHS. But it might also help people reframe what they think about working. And I hope with a lot of the work we've been doing to improve training, it might encourage you, some of you, to come back. I think one of the things when you're looking at learning, the thing is to think, what is it that I want a bit from my future career? Which sounds a daft thing to say at the beginning of a learning package that's all about responding to a pandemic. But it is an opportunity to reflect and to try and choose the best way to come back. I know some people will be coming back and working as doctors. Some may come back and work as medical support workers initially. And you may be coming back to very different grades. And part of that is thinking, what does that mean for the future? One of the nice things about this is how the NHS is pulling together and the team working, which has been a really positive aspect out of it, and I think really helps people cope with some of the pressures. So my message to you is, it's great that you're thinking of coming back. It's great that you're planning, those of you that are. I think this kind of thing that the support team are running is essential to help you feel confident. But I don't think anyone, when you start back at work, will expect to feel confident and capable, because that's just not what it's like. But I think I would like you to feel that we are all committed to making sure you're properly supported. And if you don't hear instantly, it's not because the system doesn't want you, it's because they're trying to process forms, and the NHS continues to have the hiccups that you will remember from the past and doesn't do things as smoothly as it might. But it certainly doesn't mean you're not wanted. And I think whatever you can contribute will be very welcome to the wider system at this time of unprecedented need. So that's all I wanted to say. Thank you for listening to me, and I hope you enjoy the rest of your learning session.
Thank you so much for speaking to us, Sheona. I really appreciate that, and I hope that other returners found their anxieties eased as I did. So thank you very much. All right, thank you everyone. For our second session, I'd like to introduce to you Catriona Fleming, who's a senior resuscitation practitioner at Oxford University Hospitals, and she's also a Resus Council ALS and EPLS course director, and she's here to take us through some advanced life support and particularly focusing on advanced life support in the context of COVID. Catriona.
Hello everybody, my name is Catriona, and thank you for taking the time in your precious evenings to join me as I hope to prioritise and to set out the key things that you would want to know, both at the safety huddle first thing in the morning or when you're actually going to the 2222 call. So I'm going to turn off my video and bring up my PowerPoint slides.
So I might just say, whilst Catriona works with her slides, that this isn't an ALS session, it can't count as one. But if you want this to count as CPD or for your portfolio, you should take a screenshot either of the webinar itself or of your invitation email, upload that to your portfolio, but most importantly, include a reflection on what you've learned today.
Okay, there's a couple of key things that I'm going to talk around this evening, and they are, first of all, ensuring that we've got staff safety and patient safety. Then we'll look at recognising patients at risk of cardiac arrest. We'll talk about making early and timely decisions, and then we'll talk about cardiac arrest.
Catriona, we can't see your slides right now.
Right, okay, fine, thank you. Thanks for letting me know. Okay, I'm going back in again. Can you see them now?
Yes.
Great, thank you. Can you see them now?
Yes, they look great. Thank you so much. Well done.
Thank you. So I'm going to talk around these key areas, patient and staff safety, recognising deterioration, then timely decision making, and then we'll talk about the cardiac arrest situation. So around the area of staff safety, we always talk about in the world of ALS, this whole idea of SBAR and safety huddles. So what I mean by SBAR is stating the situation you find yourself in, then talking about the background, then making your assessment, and following this, recommendations. That combined with really good communication safety huddles should be the basis at the beginning of all shifts. If we get that right, the rest is just much more easily managed. It's about the preparation. So when we think about the situation, when we arrive at either an emergency event as we respond to a 222 bleep, or a safety huddle first thing in the morning, by actually deciding what the situation is we're in, we can make much more accurate risk assessments, and then the decisions we make based on that are always much more grounded in situational awareness. So I'll talk a bit about that as I go through the whole of this presentation. I'm also going to, as I go through the presentation, talk about equipment availability and people's levels of competence, because we find that staff will be moving around the NHS and asked to work in places that they may not feel comfortable and may be new to them. And this could be, an example might be a defibrillator. There may be AED defibrillators or manual defibrillators. And it's really important that actually we understand that the staff who come to the bedside, what it is they're comfortable and competent using. And that we might want the equipment we're used to, but that we work within teams, and it's about the whole team's competence. And I think that's really important, again, to think about at the beginning of any event, whether it's the safety huddle or it's the actual 222 call. And then finally, training, very different time, and tonight actually epitomizes that. Training was face-to-face, and at the moment we need to risk assess how we can get this education in and reduce, though, this close contact. So, you know, we are going into new ways of being able to try and get messages across. And so this evening I'll be using some key videos that show some really nice simulation demonstrations, and it's as near as I can get you all to immerse in a cardiac arrest situation. But what we find with training is keeping messages simple, having standardized, simple algorithms allows people to act in very stressful situations. And marrying the scientific data and all the nuances of that, but also trying to encourage people to act in clinical practice is something that I think the Resuscitation Council has drawn together very well in algorithms and allowing us systems of working. Then we're moving on and we'll look at recognition and response to deterioration. So of course I'll mention the A to E approach. I couldn't not as I talk this evening, and a little bit about early warning scoring systems and communication and escalation. I will allude to where this has been covered on previous webinars and just add my clinical experience of this. Then we'll move on to timely decision making. Again, on previous webinars, I am aware that we did cover treatment escalation plans, DNA, CPR decisions, and really having and respecting patients' wishes at the heart of all that. and I'll mention a little bit about that, but my key talk tonight is really about that response to a 2222 call and how we would act in that situation. So before we launch into ALS, I just want to very briefly mention personal protective equipment. So the infographic that you can see here, I like this a lot because it refers to non-aerosol generating procedure PPE and aerosol generating PPE. Many people refer to that as level 1 or level 2. Some people use level 2, level 3. But essentially, there is PPE for procedures and care where there won't be aerosol generating procedures. And there is PPE that we use when there is risk of aerosol generating procedures. And you'll see that the orange section is essentially the PPE that we're using when we're caring for patients at risk or suspected risk of COVID. And you'll see she's just wearing a plastic apron. She's wearing a fluid resistant surgical mask. She's wearing gloves. However, in the green section, we've got a person prepared for aerosol generating procedures, of which I will refer chest compressions and ALS. We will be wearing aerosol generating procedures, and that's what I'll be speaking to. And for aerosol generating procedures, you'll see that we have a gown with long sleeves. We have an FFP3 respirator. We have a visor covering the whole face, and we have gloves. And the key messages for our safety is that advice is changing regularly on Public Health England, and we need to be guided by the evolving science. We'll always be looking at that, but as I give my talk this evening, this is the most up-to-date information that I have. In the context of cardiopulmonary arrest, we will be wearing aerosol generating procedure PPE, and that is referenced on the Resuscitation Council UK website, and at the end of my presentation we have links that you can click into all of these sites and read this at your leisure. I think what I would like to say is that in a very stressful situation, as you're responding to a 2222 call and people are saying to you the patient isn't breathing, it would be very, very tempting to rush and to put this PPE on incorrectly and to provide no safety for your use. And so having a buddy who will help you get into this aerosol generating procedure PPE is absolutely critical. And it'll be one of these things we'll look back and think about good human factors. I also want to say that actually when you're taking off this PPE, it's even more important that we take time to do that properly. You'll be filled with adrenaline, you will be thinking many things, but as you're leaving that patient area, the aerosol is on that gown, and in order to protect you, how you take that off is going to protect your safety, and as you walk to other patients, prevent you passing that on. So again, look at your local procedures and really take time to think about giving yourself time to do that. And we always recommend this idea that there would be a gatekeeper and a buddy outside the room where the 2222 call had been initiated from. And this gatekeeper is doing two things. they are minimizing the amount of staff who will go into that room in this very stressful event. We say it should be no more than 5 people, and ideally 3 to 4 if we can have that occur. And as I go through this evening, I'll talk about those roles and the role allocations. And this gatekeeper can, as I say, let people into the room, but also as people are getting into their aerosol generating procedure, PPE, they can help them to make sure that it's tied on properly and that they are putting on the visor properly and that the gloves are going on properly. So just a little bit on recognition and deterioration, as this was covered in previous webinars. I like to talk a little bit about oxygen requirements. What we're seeing in clinical practice with patients with COVID is that they are experiencing respiratory failure type 1, and their oxygen requirements is a key factor in airway and breathing. And what we're seeing is that their oxygen saturations are falling, and that we are putting into place specific criteria within the ABCD approach. So if patients in the OUH require 8 or more litres of oxygen to maintain their saturations at normal levels, then that would be the trigger to call our respiratory consultants to come and assess them more fully, to bring in ICU, and to think about further oxygen treatments and the benefit to the patient. Again, we will go through the ATE and take observations. We're using our national early warning scores. And what I want to say to this here is that when we're having our safety huddles in the morning, really this is the time where it would look like we have 30 patients on the ward. Who is triggering? What are they triggering with? And really, we want to be thinking about treatment escalation plans. A good safety huddle would look like everybody in this area has a plan of care. And it's not about taking away treatments, it's about individualized care where every patient has a plan. It's been discussed with the whole team. We've used our senior colleagues early in the day when they're around, and they've given us the benefit of their experience, and that it's written down in these treatment escalation plans, so that by 6 o'clock in the evening or 2 o'clock in the morning, we've got the beginning of the day right. And this is about us as doctors and nurses on our ward rounds at the beginning of the day, saying to our senior colleagues, this patient hasn't got a TEP. This patient, we haven't thought about their wishes or DNA CPR, and this is the ward round, this is a safety huddle, and I'd like this addressed. By planning early, what good would look like is a very, very few or no 222 calls to patients with COVID that weren't planned. Again, in our safety huddles, what we're finding is we're really stepping up our communication needs, and we are clarifying the level of PPE for the patients within our remit of care, and we're thinking about end-of-life care. We're calling on our palliative care team members, both the palliative care specialist nurses and the palliative care consultants, because if these patients are dying, this is our chance to have excellent end-of-life care. And for many staff who are moving environments, and an example of this is one of our hospitals in the OUH is a specialist orthopedic tertiary centre, which is a very clean site until COVID came along. And our orthopedic surgeons are really stepping up to the mark about treatment escalation plans, and our rheumatology consultants are working in teams to think about, actually, let's get TEPs in for this site. And there is some real changes happening in hospital sites that may not have thought that way beforehand, but they might like a little bit of help in good end-of-life care from our palliative care specialists who might come to that site and help us upskill with things like syringe drivers and really excellent end-of-life care. So what I'd like to now come on to is the main meat of this talk this evening, and it is the advanced life support algorithm. Now, what you've got up in front of you is the National Resuscitation Council UK informatic on the ALS algorithm. And afterwards, I've put a link for you to click on an excellent simulation. This is available on YouTube. The charity Resus Council has put that into the public domain on YouTube. And thank you for that. And this video, and I would encourage you to look at that after this presentation, has both a really good balance between human factors, communication, team leadership, roles and allocations, as well as the technical skills and the actual algorithm that we would go through if a patient stopped breathing and had no cardiac output. And I just wanted to put it up to show you the algorithm itself. And now I'm going to move on and actually put up this ALS algorithm, but the modified version of this for patients who are suspected or are COVID positive. I appreciate that the slide in front of you has a lot on it, a lot of text, and so might be difficult to read. So what I'm going to be doing shortly is you will see that at the top there's phase 1, then there's phase 2, and then finally at the end of the page there's phase 3. And as I go through my slides, I will break this up so that the infographic is much clearer and there is less text on the screen. But I wanted to show you this in its entirety so that you could see at the very top of this modified ALS algorithm that there's phase 1, and it's all about deciding if it's the right thing to do cardiopulmonary resuscitation. Phase 2 is about getting going and doing that safely and deciding what side of the algorithm we're on. And phase 3 is about thinking about reversible causes. Now, the way I'd like to do this tonight to try and get a bit of interaction going is I'm going to play a video for you now. Now, this video was made by Imperial College London, where they have done a really brilliant demonstration of this algorithm that you're looking in front of you. As with all videos, it's not perfect, but they've given us this wonderful resource that we can look at. And what I'd ask you to do, it takes 9 minutes, is to grab a pencil and a page and write down any questions you have as a result of the video. And I've also got a quick quiz or a question for you, and that might be, when you're watching the video, do they give the patient any drugs or any fluids? And if they do, how many times? So I'm going to play the video now, and then afterwards we'll talk about that.
Hospital advanced life support algorithm.
Perfect.
These changes were updated and released by the Resuscitation Council UK on the 26th of March 2020, yesterday. Today, in this simulation, we will present an adult in-hospital cardiac arrest in a suspected COVID patient. There are 2 overarching principles. Number 1, early decisions regarding treatment escalation and not for resuscitation need to be made early and communicated with the team. 2, chest compressions is considered aerosol generating. As a consequence, full personal protective equipment must be worn by every individual in the room before chest compressions is commenced.
We would like to present a 50-year-old gentleman who's come in with a cough, breathlessness and fever over the last 7 days, worsening and being admitted to hospital yesterday. Today he's deteriorating rapidly, and the team already knows that they will go all out for him, including resuscitation and intensive care.
John? John, can you hear me? John? John, can you hear me? Can I have some help, please? John? He's in cardiac arrest. Put out an adult COVID cardiac arrest. 2222.
Adult COVID cardiac arrest in the sim lab.
Analyzing the heart rhythm. Do not touch the patient. Shock advised. Stay clear of patient. Deliver shock. Now. Shock delivered. Pause. If needed, begin CPR.
Good, sir.
Adult cardiac arrest, received a single shock. I'm going to lead, then start chest compressions.
We'll be with you.
Analyzing the heart rhythm. Do not touch the patient. No shock advised. Pause. If needed, begin CPR.
Okay, some double check you. Yeah, you're good to go.
Okay, thanks.
Right, next.
Take over, don't worry.
Okay. Right, I'm just double check you. Yeah, you're good to go.
Okay, let's go in.
Right, Claire,
Hi, Claire, you get up to the top end. Okay, so what's the story?
So 50-year-old admitted last night, community acquired pneumonia, COVID test not back yet, now deteriorated, hypoxic, initially shockable rhythm, shocks, And now in PA.
Okay, no problem. Can we give some adrenaline if it's PA? Okay, so can we get some adrenaline, please?
Yeah, the adrenaline's here.
Okay, could you take the adrenaline and give? Okay, fantastic. Carry on the CPR. Claire, tell me when you're ready to intubate.
Okay, getting ready now.
Can I just confirm he's definitely for resuscitation?
Yep, resuscitation.
Okay, fantastic.
Can you in?
Yep.
Okay,
3, 2, 1.
great. Thanks. Take over. That's great. Have we done our pulse check to make sure that there is still different PEN?
Yep.
Okay, fine. So carry on the CPR until we intubate. Can we go through the possible causes? Has he had some fluids?
Yep, fluid's still running.
Okay, fantastic. He's in hospital. He's not going to be hypothermic. Okay, so can we check the potassium, please, from this morning?
Yeah,
I'm ready. You want to check?
Okay, so stop. Pause that, please, while we intubate. Tell us when you're done, Claire, and we'll start massage again.
Okay, we've got potassium as 3.9 this morning.
Okay, fantastic. So we've done hypotension, we've done hypokalemia, okay, and we've done hypothermia. Okay, what are we missing?
Analyzing heart rhythm. Do not touch the patient.
Okay, fantastic. So can we do the T's as well? Okay, we'll see.
No shock.
No shock. Clara, you ready for CPR?
Yep.
Okay, can we just do one inflation just to make sure the chest is rising?
We're on
Okay.
the oxylog.
Okay, so both sides are going up. It's unlikely to be attention pneumothorax. Okay, have we got any opportunity for an echo?
There is no echo available.
No echo. I think tamponade is highly unlikely. Okay, what drugs has he had?
So you had some antibiotics about 4 hours ago, nothing else prescribed.
Okay, is any rash?
No rush, I can see.
Okay, fantastic. And I think thrombosis is unlikely. He's been in for a short period of time only. Carry on CPR. We're going to do a cycle 2 minutes. We'll hear when it's 2 minutes. Okay, you're happy with the airway?
Yep, it's tying in.
Okay, well, if we do get this guy back, we need ITU. So can you check with ITU if they've got any capacity at the moment?
Yep.
Okay. Okay, so...
Hi, is that the ITU consultant? Okay, I've got a 50-year-old who's COVID positive, who's gone into cardiac arrest down on the wards. Have you got any capacity there to take him if we were to get Ross back? Okay, we'll let you know. Right, so the ITU consultant will be down shortly. They have got one bed available.
Okay, have we done 2 minutes yet?
That has been 2 minutes.
Okay, can we do a pulse check, please?
Okay, yeah, I can feel a pulse.
You have a pulse, okay, let's do a blood pressure. Okay, if there's any chance of doing an ECG, okay, we should do an ECG. And can we probably at this stage do a gas, okay, just to make sure that everything is okay. So we'll get the gas syringe done. Okay, well done,
Gas
team.
syringe here.
Okay, let's take the gas and send it off. Fantastic. Okay, so team, are we happy? Are we safe?
I'm just going to do an ATE assessment.
Assessment complete?
Yeah.
Okay, and the scenario is complete. Thank you.
Just checking we're all back and you can see my PowerPoint presentation again.
Yes, some people had said that the slides were slightly blurred, so I wondered if you could optimize those for slides.
Okay. So is that clearer?
They weren't blurred for me. I hope that's clearer for other people.
That's very clear, Catriona.
Lovely. Okay. So as I've said, I'm now going to use that video and I'm going to go through in more detail, pulling out some of those visual stimulus that we've seen to make it more realistic for you. So you can see that phase 1 is all about this idea of actually identifying patients that would never benefit from this medical treatment and this become a brutal treatment that was not going to work, and also the 4 or 5 staff in the room have spent 45 minutes, half an hour, exposing themselves to the virus, and this is just suboptimal when at the safety huddle in the morning, or even prior to that, we could have decided if this was necessary. So absolutely critical. So when you're running to these events, do have that in your mind, because sometimes when you're coming back, you're thinking about soda bicarbonate and worrying about H's and T's. But for me, in clinical practice, this is such an important part. So moving on to patients who are going to receive cardiopulmonary resuscitation, I think the key things that I'd like to pull out, the modifications, and you'll see them in the video, was that when they actually confirmed cardiopulmonary arrest, they modified that by feeling a pulse and looking for breathing, but they kept their face well away from the patient's nose and mouth. So that would be a key thing to say. Once they've decided that the patient is in cardiopulmonary arrest, they call for help, and they make sure that the 2222 team is contacted, and that they state that this is a suspected or COVID positive patient, as that helps the team as they're arriving. And the person who is in the room and has confirmed cardiopulmonary arrest, who is in non-aerosol generating PPE, so just the surgical mask and the disposable apron, it is best placed to think about early defibrillation. So the defibrillator was rolled into the room, and this video shows very well the AED function on the AED function, and some defibrillators are just little AED shock boxes, but many of the big manual machines have got an AED function on them. It's so much easier to use, and because it's easier to use, it actually allows you to shock more promptly, and I would really encourage you to think about AED use. So the first person in the room put the pads on, and again, in real life, cutting off somebody's clothes and sticking defib pads on a very clammy chest takes time. And we encourage people to think about doing it properly and really making sure their attention to detail, putting those pads on so that the rhythm is easier for the pads to see, and that when we do give the shock, that it's going to get through to where it needs to do. And the AED will do all of that for you. You just need to press that shock button. Now, the key thing to say about this defibrillation with the AED is that the patient may have had some oxygen on their face. They may have been deteriorating with an oxygen mask, and it may, be flowing, even up to 15 litres if it was a non-rebreathe mask. So it's important to turn the oxygen off just momentarily while we give that shock. And you've seen that demonstrated very nicely in that video. So you can see that the member of staff in that room has lots to do while they're actually giving a safe shock. For those of you who are ALS and are manual defibrillator trained, you'll see in this section of the algorithm that they say we can give up to 3 shocks. I think it's important to point out that a manual defibrillator allows you to give a shock, to analyze the rhythm and give another shock immediately, and again to analyze the rhythm and give another shock. But an AED does not allow you to do that. Again, back to my first point this evening, and that is, it's important to know the team's skills and their level of competence and to work with that. Most first responders are going to use an AED in the wards, and so will give 1 shock. Outside of the room, the team are assembling, and you could see in that video they were taking time to put on that aerosol generating procedure PPE. And you could see in that video that actually one of them put their full gown on, and even at the back it wasn't completely sealed up. And in a way, sometimes having these little things that you can see, you think, oh, we really need to take time to get that right. But once they're fully donned, they can start to go into the room. Now, in clinical practice, we've allocated roles so that we make sure that we minimize the amount of staff that are going into that room. So there is already the first person in the room who has given the shock, and they are going to leave the room to put on their aerosol generating procedure PPE kit. So the first person going into the room in full aerosol generating procedure PPE kit, I think initially was the team leader. So he is going to run the whole cardiac arrest. Shortly after him, there was the airway person, and depending on the trusts and hospitals you're working on, that might be the luxury of an intensivist or an anaesthetist. But in some hospitals, you might not have those staff with those skills, but there is somebody going to the airway. So that in the room is 2. Then we're going to have the nurse coming back in PPE, that's 3. And then we might have that extra 4th person coming in. Really, when you're getting to 4, we're coming to the ceiling of amount of people in the room. We would suggest 5 at maximum. So just think about those roles and the people who are going into that room. So when the people are going into that room, obviously chest compressions need to start as soon as we can, and they are not changed. We want them to be deep and effective, and we're giving 30. People at the airway are beginning to get ready. And if they're not ready, we'll just do the continuous chest compressions while everybody is being led by the ALS team leader. That is, that's that slide there. Moving on. Okay, so we now have 4, possibly 5 people around the patient's bedside, and we really need to try and secure this airway, because at this airway, this is where the aerosol is being coming, and it's filling the immediate area, and it's presenting risk to this staff. The ideal would be to put down an endotracheal tube, to put the cuff up, and you've seen in our video that there was a HME filter put directly on top of the endotracheal tube to stop that spread, and thereafter that you can put on, if you have it, waveform capnography or some sort of colorimetric CO2 device, and then you can put on your bag valve or your water circuit. In our trust, at a local level with risk assessment, we felt that we'd still keep the ratio of chest compressions to ventilations 30:2. We did that because we really wanted to emphasize safety. And we felt that when the airway person is going in full PPE, making it difficult to work with and hot, performing intubation is not easy. And if there is any degree of leak, we want to minimize any problems. And so giving 30 chest compressions and 2 breaths, again, just makes that safer. So we've got essentially now the airway protected. We've got our chest compressions going on. We've got our defib and our AED timing us, which is really helpful. The AED will now look to see if the rhythm is shockable or the rhythm is not shockable. What we're finding in clinical practice is that the rhythms are usually non-shockable, although some are shockable. And in the video that we've just used, the first rhythm was shockable, and then thereafter it became non-shockable. So we only gave 1 shock. And if we stayed on the shockable side of the algorithm, we would, at the end of the 2 minutes of CPR, give a second shock if that was needed. We do another further 2 minutes of CPR. And at the end of those 2 minutes of CPR, coming up to the 3rd shock, again, if that was needed, we give a 3rd shock. And after that 3rd shock, normal ALS procedure is that we would give 1 milligram of adrenaline, and it would be followed by 300 milligrams of IV amiodarone. No changes there. On the non-shockable side of the algorithm, we're just doing 2 minute cycles of CPR, and they're punctuated by assessment at the end of the 2 minutes to check that we are still in a non-shockable rhythm. There's no obvious signs of life. For COVID-specific things, it would be important that the buddy outside the room can hand us things. And one of the questions I asked was, what drugs did we give? How many times? And you'll see that there was some IV adrenaline passed from the gatekeeper and buddy to the people in the room. While the 2-minute cycle is going on, you'll have seen in the video that the team leader went through the reversible causes. But even before that, he optimized the CPR. He made sure that there was good quality chest compressions. You might want to consider getting a Lucas device if you've got that in your trust, because again, that would help us from getting less tired. And from some early literature coming out of Wuhan, they were saying that they had to swap people around with chest compressions nearly every minute because they became very tired with all of that PPE. And again, that's exposing more people to risk. So do think about a Lucas to help your chest compressions. We want to make sure that that airway is secure. If you can use waveform capnography, that will help. Think about if you can't get IV access, hopefully that will have all been done in the safety huddle in the morning if they were at risk. You might need to think about intraosseous. And the drugs have not changed in this modified version. You may, as part of the reversible causes, think about having access to imaging and things like that. But I'm just going to go through some of the reversible causes for you. I think hypoxia in many of these COVID patients is going to be a very large contributing factor to these arrests. And so getting a blood gas, sending it off, or looking at previous ones when they were deteriorating is going to be helpful. And contacting our intensivists to see about access to ICU, should this be successful, will be important things to do. Looking at the medical notes, and of course, we will have already known if they had a TEP or a DNA CPR, but if we haven't had a chance because this was completely unsuspected, do think about that bigger global picture. Moving on, then there's hypovolemia. And again, they might be dry when they've got a lot of respiratory symptoms and they're not drinking and they've got a lot of extrasensible loss. So just some saline is something that will be on most resuscitation trolleys and it can be put up. Hypothermia, again, the real context is that these patients have had news charts. They will have had a temperature before this event, and you'll be able to see if they were hyperthermic and rule that out. And then finally, hyperkalemia and metabolic disorders and just low blood sugars. Again, that will be come from your blood gas that you'll have sent off. Moving on to the T's, tension pneumothorax, people who are managing the airway, just good quality management of the airway is to always to look at the chest and see that we've got bilateral chest movement. They're easy to ventilate. And if there's any concerns there, or we can see tracheal deviation or one side of the chest not inflating, then yes, tension pneumothorax may be something to consider. Moving on to toxins, again, looking at drug charts, looking at any infusions that they've had running up until this time might give us some clues. And really with toxins, it's about supportive treatments until we can identify perhaps what the actual problem was. And then moving on to, and that would be thromboembolic. Now, yes, that definitely could be something that is presenting itself. Again, within the context of cardiac arrest for pulmonary embolism, the recommendation, the drug we would use would be alteplase. But again, we need to think about big global pictures, and that would be that if we give alteplase, that can take between 45 minutes to an hour to even 90 minutes to be in the body to actually begin to address the pulmonary embolism. And really, it's needing to think about, is these people with their underlying comorbidities going to accept that insult and rally to that? And again, by the time you've even identified where the alteplase is, got it out and got it ready, many people around that bed and the whole team are getting a better picture about if that is an appropriate treatment to instigate. So there are the H's and the T's, and that's essentially the modifications to ALS. I'm just trying to click onto the next slide. Bear with me. I think my has gone to sleep. Right then. So this, lots of different trusts will have made their own sort of local variations of the Resus Council's overarching advice. This one just happens to be our Oxford University Hospitals one, and I've also shown you Imperial College London. And my thing would be, go back to your actual hospitals you'll be working in and ask them how they, what they have produced for you. But I think the key things to say is that if somebody is in a shockable rhythm, getting the shock in early, those people have a greater outcome of surviving. And doing it with an AED will actually probably save time in the long run for the majority of people who will be doing this. And defibrillation can definitely be done in the surgical mask, the plastic apron, and gloves. However, once we start to go into cardiopulmonary resuscitation with chest compressions and everything else after that, we need to be in aerosol generating procedure protective equipment, because everybody is in that aerosol field. When it comes to airway management, please remember to use a HME filter if you've got it, and follow local advice, because some of your trusts may not have experts around to intubate. There are some links here for a mechanical assist devices. We happen to use Lucas, and please do feel free to look at those links. And then finally, particularly in an ICU environment, we've produced a video, and it's on our Oxstar website, about how to do CPR in patients who are being nursed in the prone position. So that can be helpful for you after this is over. Okay, so I just kind of want to put things in perspective. We've just had, this is the pre-proof article that's going in the journal Resuscitation, published by Elsevier, and it has been accepted by that journal. And I'm just giving you some very early figures that have come from the main tertiary teaching hospital in Wuhan in China. And essentially what they did was they looked at 750, I'm just bringing up my notes, patients' notes, and of the 750 patients with severe COVID, 136 patients were resuscitated. 119 had a respiratory cause for their cardiac arrest. And interestingly, 113 of them were resuscitated in general wards. And for me, that's really powerful, because actually these calls were in areas where there weren't specialists, where there were probably AEDs, and whereby people would not have had loads of experiences of cardiac arrests. Interestingly, the initial rhythm was asystole. I think most people would guess that, very high. And actually the shockable rhythms were 5.9%, with PEA coming in at 4.4%. Now we're coming on to sort of the grave details, which many of us know. Return of spontaneous circulation was only achieved in 18 patients. 4 of those patients survived for at least 30 days. And only 1 patient achieved a favourable neurological outcome at 30 days. And only 5 of those patients had a DNA CPR decision. Now, of course, I do want to say that the authors of this article, which we can circulate among you, are very clear to say that this was a study just in one hospital in Wuhan. It was, the context was, it was a teaching tertiary hospital, very acute. And that they themselves cannot say that this information is generalizable. And that's all very important to say. But I don't think that some of that data will be surprising to anybody who's probably watching this webinar this evening. So I think it makes for some sobering, thought-provoking things, and really puts emphasis on this idea of a safety huddle at the beginning of the day and the shift. And this idea that when you arrive to a 2222 call, there should be 2 key questions in your mind. And they shouldn't be about, oh, can I remember the dose of alteplase? They should be, is this patient breathing? And if they're not, this is a cardiopulmonary arrest situation. And are they for cardiopulmonary resuscitation? And if they are, then it's about safely managing a cardiac arrest. But the majority of people that we go to when we ring 2222, they are breathing. It's about using A to E and deciding how sick they are. And actually, when you've done that A to E, the majority of these patients may not even need you to don into higher level PPE. You might be able to go to that patient, sit with them, and assess them in a surgical face mask, a plastic apron, and gloves, and actually just be with them. And that's why I think this data is so helpful. So I think my key messages that I'd like to leave you with, and hopefully this will give you confidence and make you sort of realize that actually it's the human factors, it's the situational awareness, it's the recognition that as a team, people have skills and that they can't do more than the skills that they have. So at the beginning of our shifts, we need to ask our senior clinicians to make treatment escalation plans and for us to understand them and to think about DNA CPR decisions early. Defibrillation can be done early. It is something we can do, and we can use just very simple PPE, this non-aerosol generating PPE. Don't do chest compressions without putting on safe aerosol generating procedure PPE. Limit the number of staff in the room. If you can, intubate early and use filters if they're available to you. And when it's finished, when you come out of that room, taking time to take off that equipment carefully could make the difference between you getting the virus or not, and you going to the next patient and passing the virus on, which none of us want to do. There's some useful links in front of you, and we're going to circulate them to you. And that is the end of my PowerPoint presentation.
Thank you so much, Catriona. I think we all found that really enlightening and useful, and particularly for those of us like myself who've never had the chance to don and doff PPE. I think that video was really rammed home the message about how different this ALS guidance is nowadays. I've just got a couple of questions for you, if that's all right.
Yes.
So we've had a few questions about airway use, which is obviously quite a variation from typical procedure. If you're one of the first people, if you are the first person in the room to be wearing the full aerosol generating PPE, would you ever recommend using an airway or bag valve mask or LMA or similar, rather than just chest compressions alone?
Okay, thank you for that question. So again, risk assessment. Some of us may not have the luxury of an intensivist or an anaesthetist. We are in full PPE, which is protecting us. So we need to think about what would be reasonable. While we would start chest compressions first, and if there's an oxygen face mask on, leave that on. But the bag valve mask can be used with an oral airway if that's your level of competence. If you can't do any more, we would never ask somebody to do something they weren't competent on. Similarly, if your level of competence allows you to pop down a supraglottic airway device, we use iGels, then that is then even better than a bag valve mask, because again, it's limiting this aerosol, so we could use that. And then finally, for people who can put down and have that wonderful luxury of an endotracheal tube, they would do that too. So that would be my answer. But I have colleagues on the panel too. If they would like to contribute to that, that would be good too. But yes.
Thank you. In the wonderful Imperial video, we saw the gatekeeper on the telephone to intensive care asking whether there was a bed available. I think I probably know the answer to this. If there isn't a bed available, what happens with a ROSC?
Yeah, it's very interesting. We had a talk this afternoon in our trust about one of the ethics leads. And again, this has got to be at a local level, because in our trust today, we did have ICU beds, and that was the reality. We weren't in the position whereby we needed to think about the resource for greater numbers and having to begin to rationalize on the bigger need. And I think that's important to say, because there may be an ICU bed. So that's the first thing. However, if there's no ICU bed and we have ROSC, okay, we still have a team around there. We can still do A, B, C, D, E. And the intensivist would come down. They would look at that patient, and then based on that local trust, they would look at all of the resources they have. That might be an anaesthetic machine being brought down to that area with the anaesthetist and managing that patient, because when you looked at the whole medical picture, they would respond to that, and therefore that care should be given to them. Whereas if there is no equipment to give that patient at all, then we're back to that ethical decision making that we don't have that to give them. And we would look at all the patients. There may be other patients in ICU who are not benefiting from treatment, who are not going to survive, and then we may have very difficult decisions to make. But what I know is that we wouldn't be alone. We have ethics people around at the moment, we have senior consultants, and we wouldn't have to make those decisions on our own. And I would refer to our ethics people, and I would look everywhere for a machine.
Thank you. I think that's a very honest and supportive answer, Catriona. A question about cohort nursing. So if the arrest happens in a COVID bay rather than a single room, do the nurses assisting the other patients in the bay, if they're not in AGP PPE, do they have to be sent out of the room?
That's a good question, and clinically at the moment, I haven't had that situation arrive, because in our trust, we are really good at identifying patients who are going to arrest. and who need DNA CPRs. And to date in our trust, we haven't needed to actually do this for patients because we were prepared. Now that may change, and there are other trusts going through, you know, the numbers are huge, so I can't speak for them. But if it happened to me tomorrow in that situation, I would, again, it's about staff safety. So I would ask those nurses to leave. And if there were patients who could walk, they could leave. But that would need to be a local risk assessment on the day. Many patients don't need a nurse by them. They'll be fine, and the nurse can leave. And then immediately after the event, taking time to talk to those patients and explain the psychological would be really difficult, and we can do that afterwards. But that hasn't happened to us in our trust at the moment.
Yeah, thank you. I think we've got a few difficult ethical dilemmas throughout all of this, so I appreciate that lots of people are there to give us support both on that and in afterwards for our well-being. And I also appreciate, as you've said, that things are different in different trusts at the moment, and obviously you can only speak for your own trust, but I do appreciate you covering that difference in opinion. So thank you very much for joining us, and thank you for that excellent talk, Catriona. I really appreciate you being here with us tonight.